what your pH is of your blood, what your CO2 is in your blood, and what your O2 is in your blood. Because if you're not breathing deep enough, that phrenic nerve is going to say, okay, deep breathe, get some, it's sending that signal to that diaphragm to tell you to breathe. Okay? So it's telling you to breathe. The controller of the rate, whether you need to breathe faster or slower, is going to be your medulla oblongata. All right. So let's kind of look at, you don't have to remember the mechanisms of breathing. I just put it on there just for kind of a review. Breathe the oxygen in, goes to the lungs. Then we breathe in and out, and so you blow off carbon dioxide. That's the whole biggest thing there, blowing off the carbon dioxide. So respiration, what I actually want to talk about there is what is the main function of the respiratory system. Well, first off, it's right there in that picture, oxygen. We have to have oxygen for metabolism in tissues. And then once we have that gas exchange in the alveoli, we have to blow the CO2 off or the carbon dioxide off because you can't keep it in the body. So keep that in mind. Secondary, breathing the lungs, when we breathe oxygen in, blow off carbon dioxide, and we have that gas exchange that is occurring in those alveoli. That is controlling acid-base imbalance. So not only do the lungs provide oxygen and blow off CO2, they also help maintain acid-base balance. So they're going to bring in O2, travel to the alveoli, send that oxygen to the tissues, pick up the CO2, and we blow it off. Meanwhile, the lungs are maintaining an acid-base balance. And air has to reach the alveoli for gas exchange to occur. And once again, the neurological control of ventilation is going to be that medulla oblongata, or the pons of the brain stem. That is the respiratory center that tells you, oh, okay, you need to speed up or slow down your breathing. So it controls the rate and the depth. That medulla, medulla, oblongata, oblongata. Y'all have probably heard of that. That only controls rate and depth, and that's going to be regulated by your pH, your O2, and your CO2 that's in your arterial blood. So the medulla oblongata is the actual respiratory system located within the brainstem that changes your rate or your depth in breathing, especially when the patient becomes hypoxemic. Then, of course, you got your chemoreceptors, which is O2, CO2, and pH. And those are going to tell you how to breathe as well. Do I need to breathe deeper? Do I need to change my rate? That's your unconscious breathing. So the chemoreceptors, O2, CO2, pH. pH is going to be determined by hydrogen ions. And that, depending on what you have, whatever your pH is, your CO2 or your O2 is also going to determine your depth and your rate of how you're breathing. So they will do a lot of changes with your rate in breathing depending on your change in pH, your level of O2, and your level of CO2. Which one of those is your major regulator of respirations? What makes you breathe, O2 or CO2? Anybody remember?
Is it CO2?
It is the CO2. The CO2 is going to be your major regulator of respirations. So if I have too much, I probably need to breathe a little deeper, a little bit faster. If I have too little, then I need to breathe slower, okay? All right, cerebral cortex. Cerebral cortex is there mainly just control the way you breathe with, like, when you swim, when you talk, or when you sing. So the cerebral cortex is kind of have a conscious control of that, right? So if you're swimming, you know how you need to breathe. If you're talking, you're thinking about how you need to breathe. And if you're singing, how you need to breathe. All right. So the lungs, for their attempt to maintain normal pH, the lungs are actually going to eliminate carbonic acid, or what we actually call CO2. So the attempt to maintain the normal pH, the lungs are going to eliminate carbonic acid because they're going to blow off CO2. All right, so let's talk about respiratory and respiratory alkalosis and acidosis. We'll come back to that one. All right, so let's look at this. Respiratory acidosis. So the best way you can learn this is to know this is going to have some type of disorder that you have hypoventilation. In other words, you're breathing very slow. So respiratory acidosis is going to deal with hypoventilation when you are breathing slow. So think about that. So if you think about that, when would a patient maybe have respiratory acidosis?
When they're heavily sedated, maybe?
Yeah, drug depression, definitely. Drug depression, yep, like morphine, paradine. Any of those drugs that are opioids can cause hypoventilation. So those could cause respiratory acidosis because your respiratory rate is depressed. The other ones we see is cardiac arrest. I'm not breathing. Okay? Cardiac arrest. There is no ventilation. That's hypoventilation. So they go into respiratory acidosis. So with respiratory acidosis, what you need to put for your notes, excessive hydrogen ions. Hydrogen ions I retain, okay? So you can just put an arrow and put an H and put ions. That means the hydrogen ions increase. I'm holding on to hydrogen ions when I become acidotic. So what does that mean? Then that means that's going to drop my pH less than 7.35. My pH is going to be less than 7.35. And if you need it, and you're normal for your pH, and that's on page 536 of your Med Surg book, the normal pH is 7.35 to 7.45. So when you have an increase in hydrogen ions, pH goes down because you have an excessive amount of acid. So your pH is going to be less than 7.35. Because your normal is 7.35 to 7.45. So what I'd do is I'd make me a little chart and put the norms, like 7.35 to 7.45. And then I'd make another little box for acidosis. And then I'd make a little box for alkalosis. And by my pH under acidosis, I'm going to put an arrow down. So that means it's going to be less than 7.35. And underneath there, I'm going to put I have an excess amount of hydrogen ions. Now, think about this. And then my other box, I need to think about CO2 because that is my regulator of breathing. Okay, so now I got to look at my CO2 to know that it is respiratory. So now I need to know what my norm is for CO2. Your norm for CO2 is going to be 35 to 45. And you now look at your pH, 7.35, 7.45. So you got a 35 if it's low, and you got a 45 if it's high. So think about this. With your respiratory acidosis, the patient is hypoventilating. So what are you doing with CO2? Are you blowing it off or are you retaining it?
You're blowing it off. You're retaining it.
You're retaining it. So what's going to happen to your CO2?
It's going to go up.
There you go. It's going to go up because I can't blow it off, right? So respiratory acidosis, increased hydrogen ions, a pH less than 7.35, and a CO2 of greater than 45. That's acidosis. And it's caused from hypoventilation when I don't breathe enough. I can't breathe deep and I can't blow that CO2 off.
Miss
So that could be, yes.
Can you say the pH again for acidosis? Because I think you misspoke.
7.35. It's less than 7.35.
Okay.
And normal is 7.35 to 7.45. So it's going to be less than that 7.35, right? And then CO2 is going to be greater than 45. With excessive hydrogen ions is what's making my pH go down. And that can be from drug depression, cardiac arrest, and our COPD patients. Those are very important to remember. I'm making this as simple as I can because we have a lot that goes on when it comes to acid-base balance, but we're keeping it simple. All right, so respiratory alkalosis is going to be hyperventilation. When do you think you probably hyperventilate? When you become what?
Panic.
What? If I was to tell y'all we're going to stop what we're doing and have a quiz.
Anxiety.
Anxiety. There you go. Anxiety is going to get the best of you and you're going to start hyperventilating. Okay? So we're going to be with hyperventilation. You are blowing off CO2. You're eliminating CO2 very rapidly. So you are blowing off CO2 when you are hyperventilating. So now you're releasing hydrogen ions. So hydrogen ions go down. So now your pH is going to be greater than 7.45. And if I'm blowing my CO2 off, where is my CO2 going to be? Less than what?
35.
35. So these are just kind of memorizations. These would be really, 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 really simple flashcards. We're talking about flashcards. Kaplan actually has pharmacological flashcards in their study too, if you look into it. So we said definitely anxiety would be one thing that could cause a patient to hyperventilate. A patient that has a head injury, they hyperventilate. Patients that have pneumonia, because they're going to breathe kind of rapidly because they're going to be tachypnic because they're trying to exchange gas. Your asthma patients, they will be respiratory alkalosis at first because they are going to be they are air hungry and trying to get air in. But then as they progress with their disease process, they will go into respiratory acidosis.
Ms. Manners,
Yes.
could an example for respiratory acidosis be a COPD?
Yes, I said that.
Okay, I didn't hear you. That's why I was just wanting to know.
Yes, ma'am. And then respiratory alkalosis, the other one that's pulmonary that we'll talk about is a pulmonary emboli because they're tachypnic. Tachypnic means hyperventilation. Okay, that means I'm breathing greater than 20 per minute. So we got pH 7.35 to 7.45 normal. We got a PCO2 or a CO2. They call it PCO2 because that's a partial pressure. So you'll see it PCO2. So that's going to be 35 to 45. Now, the other thing in this is your O2. You just need to know your levels because the chemoreceptors can come into play and you're either going to breathe more rapidly, more in depth, and that is 75 to 100. Your normal for bicarbs for an arterial blood gas would be 22 to 26, which you will not deal with at all for respiratory, for our purposes. That's going to be more metabolic. We've talked about metabolic acidosis and alkalosis. The other component of the arterial blood gas for the acid-base balance is going to be your oxygen saturation, which would be 95 to 100. It's what it should be for a normal young adult. So that's normal arterial blood gases for acid base. But we're looking at respiratory acidosis, pH of less than 7.35, a CO2 greater than 45, with excess amount of hydrogen ions. Can be drug, depression, cardiac arrest, COPD. Respiratory alkalosis is a pH of greater than 7.45, a PCO2 of less than 35, and hydrogen ions go down. And we're eliminating CO2. So that could be anxiety, pneumonia, pulmonary embolism, and asthma. So when you're looking at blood gases for these patients, when it comes to respiratory, for acid-base balance, you're looking to see with those numbers, is my patient acidotic? Is my patient alkalotic with pH only? To look at it, if it is a respiratory component, I am looking at CO2 for respiratory. CO2 component for respiratory, because that is the regulator of breathing. Any questions about acid-base balance?
Ms. Manners, if you don't mind, could you please repeat what you said? I got COPD, drug depression, and I missed the other two for respiratory acidosis.
Acidosis, I said drug depression, cardiac arrest, and COPD.
Okay, thanks. I was just missing that.
You're welcome.
Ms. Myers, could you repeat the average for AVG, please?
Which one? What part?
You said that the arterial blood gases a range, but I didn't catch.
Okay, so you have different components of an arterial blood gas. You have a pH, which is 7.35 to 7.45. You have a CO2, which is 35 to 45. You have an O2, which is 75 to 100. You have the bicarb, which is 22 to 26. And then you have an oxygen saturation of 95 to 100. And the main components we're going to focus on is pH and CO2. Because the pH determines if the patient is acidotic or alkalotic. CO2 tells me that it is respiratory, if there's a change in CO2. Did that help?
Yes, thank you.
And that's also on page 536. And this is just showing you respiratory acidosis, that it is hypoventilation. That means they're breathing very shallow, okay? Very shallow. And they become hypoxic. And this shows you the pH is low and the PCO2 goes up. So if you're very visual, this picture will help. Respiratory alkalosis. It's showing you that they have deep, rapid breathing. They are hyperventilating. And it is showing you that the pH goes up and that the PCO2 goes down. And that's really all you need to focus on that. I do not ask about signs and symptoms of that because you should have already had a class on fluid electrolytes and acid-base imbalance. So pretty much all I'm doing is saying, okay, when does it occur and why does it occur? So over here it's got anxiety, PE. PE doesn't mean physical education. That means pulmonary emboli. Okay. All right. So the next thing I want to talk about is what actually is happening to the patient that makes them have our arterial blood gases change. Well, a lot of these patients are going to have problems with their O2s, and so they become hypoxemic or they become hypoxic, okay? For hypoxia, we're going to see that very quickly because the way that we see hypoxia is by putting a pulse oximetry on the patient for hypoxia. And this is your symptoms when the patient becomes hypoxic. They become a little rat. So if you walk in a room and a patient is very restless, they're very anxious, and you notice that they're breathing very rapidly, it should key into your mind, because now they look like a rat, that they are hypoxic. Okay, they are not getting enough oxygen, so they are hypoxic. So the patient becomes hypoxic when they become a little rat. So they are going to be restless. They are going to have some anxiety, and they are going to have tachypnea. Okay, so that's what we look for. And that if we go in the room and our patient is a rat, we need to get a pulse oximetry on them very quickly. Hypoxemia is actually inadequate O2 levels within the cell itself, okay? And so we'll still see the patient become restless, tachypnic, and agitated, and anxious. So we still see all of that, okay? But a quick look to a patient having problems with oxygenation because they're hypoxic, then they become hypoxemic, is through an SpO2, an oxygen saturation. So if you see symptoms of restlessness, anxiety, or tachypnea, you need to think about a rat. And they need a pulse oximetry put on them very rapidly. So we need to know where they're at. Do we need to put some oxygen on them or not? So that's going to be very, very important. Also, if you go into your fundamentals book me find this respiratory on here really quickly about hypoxemia and hypoxia. An acid-base imbalance. It's in here under fluid and electrolyte balance. If you go to page 625 in your fundamentals book, it talks about respiratory alkalosis and it talks about respiratory acidosis as well. Also, you will see on 625, it talks about chemoreceptors, which is your pH, your O2, and your CO2. And it talks about when the pH increases, then those receptors are going to tell the body it needs to become more alkaline, okay? And when it does that, it's going to say, okay, what are we going to do? They want it to what? Breathe faster. So if the brain signals the lungs, if I am in alkalosis, it's going to tell me to slow down. So that's important to remember about that. Then also in fundamentals, I've used this book quite a bit because I really like this fundamentals book. On page 577, it talks about the impaired oxygenation. It talks about hypoxemia and hypoxia. So hypoxia, which we're looking at right now, when the patient becomes the rat, they're not getting adequate amounts of oxygen to the tissues, okay? We're not getting adequate amounts of oxygen to the tissue, like I just said. So the patient becomes restless, anxious, tachypnic, or tachycardic. So tachypnic means respiratory rate is up. Tachycardia means heart rate is up. So we'll see the little rat start to develop. And a quick look for this patient that becomes hypoxia is through an SpO2 or an oxygen saturation, because it should be between 95 and 100. And this patient's SpO2 is going to be low because they are hypoxic. And once again, hypoxemia is when the O2 levels that are in the blood drop below normal. So in other words, we have a decrease or an inadequate amount of oxygen for cellular metabolism. Now, if you walk in a room and the patient is already cyanotic, then that's a late sign. Cyanosis is a late sign. When they turn blue, that is late. Now, I have another thing to ask. What could cause a patient to have hypoxemia? What could make a patient not have enough O2 getting available to their cells that could occur with the disease process?
A burns situation?
A what?
Burns.
Why would burn?
Oh, I mean smoke inhalation.
But what would be the cause of it, though? What would smoke cause? What would smoking cause that could cause hypoxemia?
A respiratory distress because
Lung disease, like lung cancer, and you got a tumor,
right? And an increase in CO2.
Yeah. So you're chronic lung disease patients. So we see lots of causes of hypoxia and hypoxemia. So it's very important that you know the causes. So we would see somebody maybe's got lung cancer and has a tumor. Maybe you got somebody that's aspirated a piece of meat right? Aspiration of a foreign body. They would become hypoxemic. They wouldn't get enough oxygen to their cells, would they? Because they can't what? Exchange the oxygenation in the alveoli. So we could see that. Somebody choking. What about thick mucus? If you can't get the mucus out of the bronchi, are you going to have gas exchange when you try to breathe air in? Can't get there. So they'll become hypoxemic there. We said COPD, definitely. What about a patient that has a pulmonary emboli, that they've got a blood clot that's occluding the pulmonary artery? There's no gas exchange, right? There's no blood getting to the alveoli, so they will become hypoxemic and hypoxia. And then patients that have atelectasis, where they have the collapsed alveoli, there's not enough gas exchange. So hypoxia and hypoxemia is dealing with, is there enough oxygen? Do we have oxygen to be broken down or in the blood? Or do we have adequate amounts that's getting to the tissues? So that's what we're looking at there. Now, the important thing about a patient when they become hypoxemic or hypoxia, okay, is you remain calm and you stay with the patient. And you can just kind of hit the call button, say, my patient is having breathing difficulties, I need help. Okay, you stay calm, because if you get excited, the patient's going to be excited and think that you can't take care of them. Also, other things that can make your patient hypoxemic or hypoxia is anesthesia. They may hypoventilate because they've given them anesthesia, especially Versed. Versed will make them breathe a little slower. Sedatives. So your opioids, your morphine can make your patient become hypoxic. So kind of keep that in mind. So those are some causes. But the main thing is, please stay with the patient and remain calm. And please remember that blue color, cyanosis, is bad. That means that patient should have never gotten there, because you should have been on top of it and got it reported. So you don't want that to happen. If you walk in and your patient is a rat, take care of them before they become cyanotic. So take care of that restlessness, that anxiety, and that tachypnea, tachycardic before they become cyanotic, because cyanosis is a late sign. Very late sign of hypoxia. So you need to take immediate action and notify the RN and the healthcare provider. For hypoxia and hypoxemia with cyanosis, late sign, immediately yell for help. RN and doctor, immediately. Very, very important. So there's our little rat again. So keep those little symptoms in mind. That's going to be very important. So that's something you might want to highlight, circle, asterisk with your hypoxia. And a quick look for hypoxia is going to be an O2 saturation. So in other words, you're going to put an O2 sat on that patient very quickly. All right, so let's just kind of look at aging as patients get older. Well, they lose some of their strength with their respiratory muscles, because the respiratory muscles actually will start to atrophy as you get older. So we can see them actually start to decrease their force of coughing, because they just don't have the strength. Also, because as they get older, they lose some of that elastic recoil, and so that's going to make them air trap. When they air trap and they have a decreased force of cough, that puts those patients at risk for respiratory infections. So that's very important to remember, that if they don't have the muscle strength to cough and they get pneumonia, especially from from COVID right now, who is more affected by COVID?
The elderly.
The elderly. Right here is why. This is part of it, because their respiratory muscles have atrophied. They're not as strong, so they can't cough. And so that gives them a more risk for respiratory infection, which with COVID is the pneumonia and the adult respiratory distress syndrome, where they have this shock to the lungs. And also, if you think about if they have reduced elastic recall and they air trap, then they're not going to have good gas exchange either. So we'll see decreased gas exchange. So this is one of the reasons the elderly are more affected by COVID, and their immune systems are down. Okay, as you get older, your immune system is not as good as it was. Also, if you look here, they also, remember I said you have about 3 million alveoli in each lung. Well, as you get older, some of those decrease. And so when you don't have as many alveoli, you won't have as good a gas exchange with those patients. Now, other things that happens, decreased cough reflex, their cilia start to deteriorate as you get older, and so that will set them up for infections as well. So those are just some of those things to look at with these patients, the deteriorating cilia that are normally in the nose and down into the trachea that help move that microorganism up in case you get something in your body. Say that something gets in your body that shouldn't be there, we normally will sneeze to get it out, right? But if you don't sneeze and you've inhaled a microorganism, then it's going to move down into the cilia. And what those cilia should do is stimulate a cough. So that's what we're doing. We're coughing. So that's going to decrease that respiratory infection because that microorganism should not be there. And so that's the reason it stimulates either a sneeze or a cough, okay, with the cilia. And of course, if they don't have a good cough effort or a good cough reflex, then that's going to set them up for infections as well because they can't get the mucus out that needs to come out. So that's going to be very important. So when you are doing your patient's assessment, after the RN has done their first assessment and then they delegate you doing it from then on, you want to know, well, what is going on with the patient? Do they smoke? Those kind of things you need to know about. Now, if they happen to come in a clinic, a lot of times the LPNs will ask those questions. Are you a smoker? Are you know, what is going on with you? Are you having any type of chest pain? Because some patients could have chest pain with deep inspiration, and that's because they've got some inflammation of the pleura and they're rubbing together, and so they'll have pain. They may be there because they're short of breath. Well, why are they short of breath? If they say, I'm short of breath, and if they have a cough, you want to know, is their cough productive or non-productive? In other words, non-productive means it's dry. Productive means there's sputum coming out. So that's going to be important. What does the sputum look like? Is it thick? Is it got color to it? Is it green, yellow, bloody? Is it blood tinged? That would be like hemoptysis when they have tuberculosis, and sometimes with the pulmonary emboli. If they're having a pulmonary emboli, I hope they're in the ER. Then I would ask them, have you been running a fever? Do you sweat at night? Because if they come in and they say, I just hadn't been feeling well, I've been really fatigued, I'm running a fever at the night times, I'm having all these sweats, then I'm going to immediately think tuberculosis. Immediately. And I'm going to be thinking, okay, well, we need to get them to the ER and they need to have some tests ran because they probably need to be in the hospital and be put on isolation and start some antibiotics on them in case they do have tuberculosis. And we'll talk more about that as we go. But we definitely want to be assessing that sputum. So once again, is the cough productive or non-productive? What does it look like? Clear or white sometimes may be normal, or it could be a viral infection. Yellow or green, there is an infection. It's probably bacterial. We also need to know that with pneumonia, a lot of times the sputum will be rusty in color. And then tuberculosis can possibly have a little blood tinge to it. Is it pink and frothy? If it's pink and frothy, I worry about pulmonary edema, but they're probably in the hospital. They have pulmonary edema. But just remember, the longer that this patient keeps mucus, which if I have a decreased cough reflex like this aging population does, and I'm keeping that mucus down in the lungs and I'm not able to cough it up because I have a weak cough reflex, that is a great environment for bacteria to grow because it is dark, warm, and moist. So kind of keep that in mind, that this is a very, very good area for bacteria to grow. It's a good environment. So you need to make sure that these patients are able to cough these secretions up, especially if they're very thick and sticky. And we'll see that with patients that have bronchiectasis. And that's secondary to a cystic fibrosis patient. A tuberculosis patient may have some real thick secretions as well. Also, you need to know the amount of sputum that's coming up daily with the patient. That's going to be very important. So what is their cough like? So is their cough productive or non-productive? And what does it look like? Is it white and clear, which could be normal, or maybe they got a viral infection? If it's yellow or green, it's bacterial. If it is kind of a rust color, it's probably going to be more pneumonia. Tuberculosis or TB is going to be blood tinged. If it's pink and frothy, it's probably pulmonary edema. And then you definitely need to know the consistency. Is it thin or is it very thick? If it is thick, then you got to realize we got to somehow get that out of the patient because that environment is very well iterated for a bacterial growth. And leukemia, you had a question?
I was wondering, I hear what you're saying, but I'm not able to jot down the notes fast enough. So I was wondering if it's somewhere in the book where you're telling about the different variations of the sputum.
Yes, it's in Fundamentals 579. And also as we go along with the disease disorders, you'll hear it again. Does that help you? And also on 531 is your data that you're asking your patient in your med-surg book, table 29-2. Because when you're assessing your patient, you're asking them, do you smoke? If you ask them, do you smoke? Well, how long do you smoke? How much do you smoke? That's important to know. What if it's somebody that comes in and they're having shortness of breath and just not feeling good and they say, no, I don't smoke? Well, I'm going to go to the next question. Anybody else in your family smoke? Because I'm going to tell you right now, lung cancer is big time secondary to smoke from someone else. That's the reason they have come up with the idea that you shouldn't smoke in a car with children, because they could, in the long haul, end up with lung cancer because of that. So secondhand smoke can be a big problem for lung cancer. We see a lot of lung cancer from secondary smoke. Also, environmental toxins, we will see lung cancer. Then you want to ask them about history, about family, those kind of things. All right. So we just talked about this. When they come in, any exposure, smoking, chemicals, family history, we talked about a little bit. Upper and respiratory. Upper may be a cough. Lower can be a cough. Maybe they got a headache and they got a lot of sinus drainage. Well, then it's just sinusitis for upper respiratory. Could be allergies. Maybe they come in with hoarseness. That could be laryngitis. Maybe they come in with a sore throat. That's upper respiratory. Lower respiratory is going to be the productive cough, shortness of breath, those kind of things. Do they do anything for it? If it's an asthma patient, how do they treat it? Are they doing their albuterol on acute attacks? Same way with your COPD patient, when they're not breathing well and they're having an acute attack of shortness of breath, are they using albuterol? And then when they go in an exacerbation, are they having to take corticosteroid inhalers and to decrease the inflammation? So there's just a lot of different treatments that can be out there. Maybe they're using oxygen. Maybe they're a COPD patient that needs oxygen. So we need to know that. So those are some of the current treatments that we look at. Are they on antibiotics? Because they have maybe a bacterial bronchitis. Those kind of things. So the big thing is when you're doing a what I call a focused assessment, you're just kind of asking the client what's going on. That's pretty much all you're doing. What is going on? And we just went through everything that we would ask them about. Like with maybe shortness of breath. Well, when do you get short of breath? And they might say, well, moving around, at rest, those kind of things is what we're looking at for the shortness of breath. So the next thing, once we get the picture of what's been going on with the patient, we've got the subjective part where we kind of ask a few simple questions. Sometimes RNs will do this, and sometimes they will leave it up to the LPN. In NCLEX world, RNs should be doing first assessment on patients, okay? Now, then you're going to inspect your patient. In other words, inspect means you're looking at with your two eyes, okay? We want to look at the patient when we're doing inspection. Okay, we want to look at the patient. So what we're doing is we want to know what is their position. Do they have to sit up to breathe, or can they lie down to facilitate their breathing? What are they doing, okay, to facilitate their breathing? Are they always having to sit up? And when we're looking at them, all right, so we're inspecting. Also, when we inspect, we're listening to the patient talk. Do they become dysmic with speaking? And we're also looking for muscular retractions. In other words, how are they breathing? Do they have an airway obstruction when we walk in the room? This could be a child, maybe in pediatrics, that swallowed a penny. And you're looking at that child and they're having airway obstruction, so they're having retraction of breathing, muscle retraction. And you can see that when the skin pulls inward when the patient inhales. Do they have a barreled chest because of COPD, where they have hyperinflation of the alveoli? So do they have a barreled chest because they're trapping air? So that's chest shape. Okay, we're looking at that. We're looking to see if the patient is using accessory muscles. We're assessing their accessory muscle usage. What's the patient's color? Remember, Cyanosis is a late sign. We don't like to see it. Also, if you go in and your patient is having muscular retractions, where they're pulling their skin in to breathe, when they breathe, that is a late sign of hypoxia and hypoxemia as well. Please remember you're looking at rate and depth of respirations. We want to know their rhythm. Is it labored, unlabored? Respiratory rate, normal is from 12 to 20 is normal. Twelve to 20 is normal. Tachypnic is going to be greater than 20. I call it bradypnea. It's going to be less than 12. Apnea, they're not breathing at all. There's no breathing at apnea. Chain stokes are usually considered death breathing, a death breathing. They'll breathe fast, then they'll breathe slow, and then they don't breathe at all. Then you got the Kussmaul's down there, and we usually see those with our diabetic patients or our chronic renal patients where they're trying to blow off a lot of CO2. We can see that. And all of that is also in page 533 of your Med-Surg book. The other thing that you want to, no, it's not on here. The other thing that we look for when we're doing inspection is we want to look at their fingers, especially around their fingernails and their fingertips. Because if a patient has a chronic a chronic lung disease like COPD, then their fingers are going to be what we call clubbing. They'll have clubbing fingers because this is a chronic hypoxia. That means their little fingertips will look like clubs. They will actually resemble clubs, so they will look like a clubbed finger. So that's from chronic tissue hypoxia. Chronic tissue hypoxia leads to clubbing of the fingers. So inspection, you're going to look at chest shape. Do they have a barrel chest from COPD? Respiratory rate and rhythm, are they between 12 and 20? And then you can look at the different respiratory patterns. All right, color. Please remember cyanosis is a late sign of tissue hypoxia. And the way we look at a patient for cyanosis is the lips, their fingernails, and their capillary fills. So for color with cyanosis, you're looking at the lips, the fingernails, and the capillary refills. And that is a late sign of hypoxia. Now, if it is a darker colored person, then you want to look into the mucous membranes of the mouth, and they will be kind of a gray color. And also their lips will become blue as well. We want to watch for accessory muscle usage, especially retraction, because the use of accessory muscles retraction is a late sign as well of hypoxemia. We want to know, is the patient dyspneic when they're talking? Do they get dyspneic when they walk? Also, we always want to, when we're doing our respirations, you always want to look at the chest and make sure you see symmetry. Symmetry means both sides rise at the same time and both fall at the same time. So we're always looking for symmetry when it comes to respiration. Is the chest rising and falling like it should? So that's our total inspection. So remember, too, if you walk in, a patient is restless, agitated, and tachypnic, then we worry about them being a rat. And we're going to stay with them and stay calm and call for help with our inspection. All right. our next part of assessment is going to be auscultation of the lungs. Auscultation of the lungs. Now, with auscultation of the lungs, we're going to really only focus on, I call it 9 areas. 4 on the front and 5 on the back to listen for breath sounds is what we're going to do on that. So we're going to do 9 areas that we are going to listen to lung sounds with auscultation. Auscultation means you put your warm stethoscope on the patient's chest and you start to listen. And when you do that, you want the patient to take a breath in and blow it out. Okay, and you're going to do that with each 9 space. Okay, so each time you put your stethoscope in an area, you tell your patient, take a deep breath in and blow out. When we're auscultating, we want to move from side to side. So if you look at the first picture to the left, it says anterior. We want to move from side to side. So we're moving from left to right or right to left. I don't care. All right, but we're going to go side to side. We're probably going to be doing somewhere between number 3 and number 4 anteriorly. You don't have to do both. You can do either or. But we are definitely going to do number 5. Okay, 3 or 4 is okay, but number 5 we will do. Okay, you're going to do either number 3, 2, and number 5, 2. That's 4 anterior. Okay, 4 anterior places that we're going to listen to. Then if you look at the diagram over to the left, it says posterior. We're going to listen to 5 places in the back with our stethoscope. Same thing, we're going to put our stethoscope on, deep breath in, blow it out. Probably somewhere between, probably about number 3 or 4 is good. 5 and 6, either one of those places is good. So that's 3 or 4, that's 1, 2. 5 and 6, 1, 2, we've done 4, right? Then you look at number 8. We're going to do both of those because those are going to be more of the lower lobes. And then we're going to look at that middle lateral picture there. That number 3 or number 4 is going to be the best way you can listen to your right middle lobe. So your stethoscope should be underneath the arm for the right middle lobe. Because you got either 2 of number 4 and 5. You got 2 of either 6 or 7. 2, 4. Then you got the 2 lower lobes, that's 8. Then you bring your stethoscope around and you're going to listen to the right middle lobe, either on number 2 or number 3, or 4 or 3 on that one. So we do anterior, side to side, okay? Posterior, we go to the post, we go side to side. And you always go upper to lower. Don't start in the lower lobes and move up. You're going to start in the upper and move down. Now, the best way to listen posteriorly to your patient or to any lung sounds, they should be setting up. Air exchange is better with them setting up, so it's better for them to set up. We want to make sure that they do a total inspiratory and expiratory release. Okay, they should do an entire inspiration, breathe in, breathe out. Okay, that's going to be very important, and they should set up for this. This is the best way to listen to lungs. And there are some YouTube videos that, or Khan Academy is a really good one too to watch. But find you some YouTube videos and listen to these breath sounds. Also, F.A. Davis Edge, you can go in there, and they actually have videos as well. and you can hear normal breath sounds and adventitious sounds as well. I highly recommend you get good at this for the fact NCLEX will ask questions about breath sounds. They will give you a sound, and then you got to figure out what breath sound that is. Okay, is it normal or is it one of these adventitious sounds that we're listening to? And of course, when you're in nursing school, we don't expect you to be able to determine is it a wheeze, is it crackles, is it bronchi, is it stridor? But some of these are so prominent, you should be able to figure them out when it's an adventitious lung sound. If you're not for sure, if you can't figure out is it a bronchi or is it a crackle, you need to just have the instructor come in and listen with you, and then you can kind of decipher between them. And when we go to Sims Lab, a lot of times, I don't know how much time we're going to have this trimester, with our lung sounds, I always do an oxygen administration, and they listen to different breath sounds. And then if they say, well, I'm not really sure what I'm hearing, I think it's this. And so I'll turn the mannequin on and I'll let them hear what they think it is. And I'll go, okay, now this is what you're hearing. So then I'll turn it on what I have it on. They'll go, oh, yeah, I see the difference. So you got to kind of compare them. But the best way you can do this is by getting on YouTube and F.A. Davis and listening to these breath sounds, because they do test that way with sound. They'll make you wear the headphone, and then you have to figure out what sound you're listening to. Is it normal or do we hear adventitious? Okay. So adventitious means it's something abnormal. Okay. Adventitious means it's abnormal. So that's the second sentence there in that first word. Adventitious means it's an abnormal lung sound. So when we're auscultating, we're going to hear something abnormal. Okay? So that's going to be very important. What am I hearing when I'm listening? And like I said, we do not expect y'all to be perfect on lung sounds. Okay? We just need to know you hear something that's not right. And like I said, we're going to go side to side, top to bottom, and we're going to, side to side means we're comparing bilateral. All right, so let's look at our different types of adventitious breath sounds that we can hear. This is also on page 535 of your Med-Surg book, these sounds. The crackles, you do not have to remember coarse or fine. You just need to know what they are and when you hear them. The crackles, or what we used to call rales, R-A-L-E-S, because some tests still use that word, which I'm surprised. It's a very discreet sound. If you take your hair and you rub it next to your ear, that is what crackle sounds like. Or you can pour milk into Rice Krispies and hear a popping sound, and that is crackles. So it's kind of on inspiration. It results because there's a delayed opening. There's a delayed opening of the deflated airways. So crackles sound like this discrete sound of your hair strands rubbing together. So inspiration, and it results because you have a delayed opening of deflated airways. This is fluid on the lungs. So what you're actually hearing is fluid and air at the same time. Okay, fluid and air at the same time. So you got fluid and air, or what we call secretions in the airway. So that's when you hear crackles. This is usually heard with pneumonia, heart failure, and pulmonary edema. So we can hear this with pneumonia, pulmonary edema, and heart failure. So this is secretions in air. Okay, when they take a breath, you're going to hear this crackle on inspiration. And it's from delayed opening of deflated airways. All right. The next one that's advantageous is wheezing. This is narrowed airways. It's mostly expiratory. We usually hear it with our asthma patients. We can hear it with COPD, and we can also hear it with pneumonia patients, but asthma is the ones that we usually hear it with. So narrowed airways, expiratory, it's heard with asthma patients, and it's musical in sound, has a musical sound. Another one that you may hear when a patient needs to be suctioned is called rhonchi, R-H-O-N-C-H-I, R-H-O-N-C-H-I, rhonchi. That's when a patient needs to be. The way you distinguish rhonchi from crackles, rhonchi will go away when the patient coughs. Rhonchi will go away when the patient coughs. It is heard on expiration, and it sounds like a patient is snoring. So rhonchi will go away or clear with coughing, expiration, and snoring is what it sounds like. So that's rhonchi, R-H-O-N-C-H-I. The pleural friction rub, and we'll stop there. And we'll talk more about this tomorrow. Make sure you have your respiratory diagnostic testing papers ran off, or you can type into them tomorrow when we go over the diagnostic test, and then we'll move on and get to chapter 30, okay? Chapter 30, let me see, give me just a minute, I'm gonna get y'all off of here. Chapter 30, I do not do epistaxis. I do not do nasal polyps. I do not cover deviated septum nor rhinoplasty. We start sinusitis in chapter 30. I will not cover sleep apnea. In chapter 30, I will not cover pharyngitis nor laryngitis. Everything else there I will. In the remainder of this chapter, 29, we will not talk about nebulizers or inhalers or chest physiotherapy. Let's see, do I? Yes, we will. I'm sorry. We'll talk about chest physiotherapy. We'll talk a little bit about thoracentesis. I will not hit on chest tubes with this chapter because I do that with pneumothoraxes. So you don't have to think about that part right now. So you don't have to read that. So you want to do oxygen devices. You don't have to read the pursed lip breathing for right now. No pursed lip breathing. No incentive spirometer. No chest tubes. and no trach for right now. Those we will come back to when we get to the disease processes. So I highly recommend for tonight, you go ahead and run that paper off and have it ready, or if you're going to type into it, that's fine as well. And then I would definitely go to F.A. Davis and listen to these sounds. Okay? And I don't know if we'll get to our medications tomorrow or not. Any questions about today's lecture? It's pretty simple. And I will get with the people that need meetings with me, and I'll set some meetings up with you. All right? Any questions about today's lecture?
Miss Manners?
Hi, yes.
I just want to clarify what time my meeting is with you, because on Teams it said one time, and in the email it said another time.
Yeah, I wanted to meet with you at 12:45, Rebecca.
12:45?
I mean 2:45. Good Lord, help me.
Okay.
2:45. Yeah, 2:45.
That's sorry. That showed when my meeting was. The other Rebecca.
Do what?
For Rebecca 2, you had me at 2:45.
Today?
Yes.
No. Thought I met with you last week.
No, not at all. No,
Oh,
you
I
put it off to the 19th. I got a reminder today that it's 2:45.
Oh, yours is at 2:45?
Mm-hmm.
All right. Well, see, I got two Rebeccas, so I don't know who I've set up with appointments with. So Rebecca Coles, what time did I tell you the first time?
In the email you said 5:30.
5:30?
Yeah.
17:30?
Yes.
That ain't right. Just meet with me. Let me look and see what I've got on there, and I'll fix it. And you just meet with me can you meet with me at 3:30?
Yes.
Okay. All right. So let me write this down so I know which Rebecca's I'm meeting with, so I know. Okay. Rebecca.
Manners, you have a good rest of your day.
All right, you too. Rebecca Chu, I'm going to meet with you at 2:45. Lord help me.
Yes.
And Rebecca Coles, I'm meeting with you at 15:30. Okay? And I'll change it. I'll take you out for the other one.
Okay, awesome.
Okay? All right. Thank you.
All right, thank you.
Anybody else got any questions?
Yes, this is Rahel.
Yes, ma'am.
So I tried to email to you as any way I can share my screen and I can show you what I can see on my screen.
I sent you another email. I found it. What's happening is if you have ever done that in the past, like it looked like you had played around with it in the past, then what it did was it showed me the old one and there was no remediation. So then I had to figure out, because this is a new setup they have. So I had to go over, I had to slide it over, and it gave me the date that you did it again, but it doesn't show me the remediation. It just says this is how many minutes of remediation was done.
Yeah, but
So when I first look at it, it doesn't come up that way. I had to really get into it to figure out where this was. And it was because you apparently had done it maybe in first. I don't know. But it was a different date.
Yeah, I did it last night, both of them. But like right now I'm seeing it on my screen. I can like share or I can.
No, I took care of it. I found it. You're fine.
Okay. Thank you so much.
I'm just telling you, I had to look for it.
Okay. Thank you so much.
Anybody else have any questions? Yes, Wilkema.
Okay, this is just for my clarification because I'm trying to try something different. So I know you told us to do the respiratory diagnostic, like we'll have it printed out and have it ready.